The world's best physios don't just treat, they coach. Welcome to the Physio Coach Podcast. This episode is sponsored by Jane App. Jane is a practice management platform that helps clinicians like you and I spend less time on admin and more time caring for people. From online booking and scheduling to notes, reminders and billing, Jane is designed to reduce the day-to-day load on busy clinicians like us. After a few years of running Better Physio Group, we wanted to level up our practice management system. 10 minutes into the demo call and I was convinced. Use code Physio Coach 2MO, that's Physio Coach 2MO to get 2 months free. Sign up to the demo and see it for yourself. This podcast is a product of Better Physio Group, provider of physio and PT services in central London, helping people in pain, suffering with injury to feel better and live better. There's physio and then there's Better Physio. In the spring of 2021, I started playing football again for the first time in about 15 years. Enjoying it. I was playing some five-side, scored a few goals and running around and having that buzz about sport. And in the act of scoring a goal, top corner by the way, I was then tackled on my standing leg and had an inversion sprain on my left ankle. And that sprain was a pretty high-grade injury, and future scans would then show ATFL, high-grade rupture, CFL injury. I think it was a partial AITFL. So it was a proper injury that I needed to take seriously. I was in a boot, crutches for a couple of days, and then there was a moment when I realised that this isn't the kind of injury I should rehab myself. This is 10 years into my career, 11 years into my career, and the wisdom of that time starts to help you make smarter decisions, not just about other people's injuries, but about your own. So I outsourced my physio journey to a trusted physio who is with me today, Rebecca Christenson. Welcome to the show. 2021, I became a patient with you for the first time with my left ankle injury. Then if we just give a quick summary of all of the stuff that has happened around my two ankles, and then I'll bring you in properly, Rebecca. So I rehabbed 3, 4, 5-ish months from that particular injury, and that's been great. I then decided to have surgery on my right ankle, which we'll explore in a bit, and you then helped me rehabilitate post-surgically for that a year and a half ago. And I would now confidently say that both ankles feel amazing. So job well done. Thank you very much for all your support on that, Rebecca. And what was your, let's go back to 2021, spring 2021. It was April, and I hobble into work with this big fat ankle, and I've done myself some damage. What are you thinking around that time? You've probably seen all this before, right?
Yeah, I mean, going back to your injuries, I mean, it's a team effort, and obviously your surgeon did a very good job. But I think, I suppose I've learned one thing over the years, that it's easy to be too keen and get going too quickly. And yeah, probably looking at the size of the swelling and knowing the injury, it's really, really important to kind of close things down in terms of function, so that you can work specifically on range and, as appropriate, proprioception and strength. But I think that early on, I think I would have probably been really keen to get things going. And whether I read that in you as you were walking past, being really keen and just, I suppose seeing other colleagues, I don't know whether you worked with Jim Zouch, but I remember him with probably an equivalently bad injury, standing on a Bosu ball in the gym with it being equally fat. And I said, no, you need to be in a boot. Yeah. And so, it's getting, I think, really important to get the staging of what your interventions are.
It was
according to the...
Yeah, it was definitely a shift in my management of acute injuries, is to do less in those early stages rather than to try and make extra progress in the early stages. And that kind of concept of less is more really rings true for me. Luckily I had some words of wisdom on my shoulder to give me a little nudge. And there was... When I was realising that I needed a physio to take charge of things, because as as any physio who's tried to manage their own injuries knows, you get too emotional about it, you make bad decisions, and you either overdo things or underdo things. You're just not thinking rationally. I had to really consider who would be the right personality for me and who would be the right clinical fit for me. And obviously you're a foot and ankle specialist, so that side was already a given. But there was plenty of good physios at Pure Sports Medicine, the clinic that we worked together at the time, that I could easily trust on the clinical side of it. But for me, there was always a personality match that I was looking for. I am a little more on the let's get going and let's push things side as a physio and as a person, and you've always been a little more on the let's just see how things go, let's be a little more cautious. And I recognised the need for me to work with someone who wasn't like me. So you did definitely fit the bill for that, and I've been a beneficiary of that style for now both of my ankle recoveries. And is that a style you've always had, or is that something that you've had to work on over your
No, and
career?
I would actually say I'm not even sure that it is my style. I think it is with you because you needed that. I think that I would say that I have thought about, my career, and obviously in the beginning part of your career, there's a lot of kind of, knowledge base you need to get. You need to get a lot of clinical experience. And I've sort of thought, what have I learned in the last years? And I think I've got better at reading people. And so, sometimes somebody like you, it might be that I need to kind of slow you down and give you the evidence of why you need to slow down. But there will be people that I massively need to motivate, and it's about selling them to kind of get going and making what I want them to do so achievable. It's like one thing, it's not six, and they only need to do it twice in a week. I mean, who can't do that? So I wouldn't say that I certainly have learnt to respect acute injuries, and that's probably from thinking that I could beat nature. And I don't think you can. I think, you have the human body is amazing. And, the whatever that saying is, medics amuse patients while nature takes care of the disease, or something along those lines, is probably, not too far away from the truth. In the acute stages, and I think it's so easy to overload. We're busy, walking load, standing load. So I think that side of things in an acute setting, I would say that is me, and that I've learned from not being happy with the results that I was seeing in my patients. But I would say if I look across all my patients, I think I have learned when to push and when to pull, and it's about reading the person, I think, that I've developed.
I think you read me just right, because I do have a tendency to push a little too hard with my own injuries. So it was the right read. What I've just realised is I also didn't. Another part to the diagnostics once I'd had the MRI was that I had some pretty chunky bone bruising as well. So there was quite a lot going on in the joint as well. It wasn't just the ligaments, and in the end, that was the bit that was really holding me back from getting back to the running I was trying to do. So we'll come to that shortly. But once you've got that multi-structure injury, this high-grade ankle sprain injury, how do you get that across to a patient who doesn't understand that? So it's slightly different for me, because I had some level of understanding about these structures as a physio, but if we're trying to help the physios listening to this, how do you explain the importance of wrapping that injury up and packaging it up in protective boots and stuff like that? Yeah,
well, I think there's sort of two parts to that. There's the acute part, and then there's the return to impacts part, and I think both are really important. And I guess in the early phases, and it's only on my experience, I suppose, the evidence of what I've seen, that I've learnt that. And I think that must come across when I speak to patients. They can see that I've seen a lot of it before. But I think it's really important in the first few weeks to be in a boot. But then if you're thinking about something like bone bruising, that's something with an ankle injury, people will often get focused on whether it's stable or not. And actually, a lot of the time, you can have ruptures, complete ruptures, and you don't have that functional instability. The biggest problem is the stiffness, the bone bruising, and the lack of tolerance to returning to impact. And I think, I'm not sure whether I'm answering your question, but what I was thinking is that I will often, very early on when I see people, I will give them a framework and say, look, this part of it is going to take, a few weeks, but the ability for the bone, if it's got that degree of bone bruising, to restore its low tolerance is going to be more like months. So it's setting an expectation so that the patient isn't thinking, which maybe they might do because an ankle sprain is sort of relatively common. So perhaps people are thinking, oh, I can get back in a few weeks. But actually laying down, and I had a lady recently, and I sort of wrote down everything, drew it out, and you quite like diagrams, showing exactly, gave her an explanation of what the different roles of all the different ligaments that she'd damaged. Is like yours, it was a high as well as a ATFL and CFL injury, as well as bone bruising. And I think understanding the complexity of it being written down was a good way for the patient, at least, to sort of see. And I said to her, the biggest one there is the bone bruising and the AITFL. They're the ones that you need to respect the most. And, you could see she could really hear that. So I think it's taking the time to explain, because if it's going to have a big impact and someone's going to have to sacrifice a lot, they need to understand, and they need to have the time to ask questions and think ahead. And I'll always ask, what are you planning, so that we can look at whether that's appropriate. So is your kind of trekking in North Africa going to be appropriate if you're doing it in 6 weeks' time?
And what are the connotations of not getting that bit right? So obviously the two of us have learned from experience to some degree as well here, where people haven't done so well. But if you don't stabilise and protect that injury in the first few weeks, what then happens to those structures that have been damaged?
Well, I would say, highly likely to have more increased risk of long-term stiffness, definitely more damage to the chondral surface, leading more likely to problems like arthritis, and I mean they're the biggest ones. I don't necessarily think that instability is particularly a problem. It is about protecting the weight bearing, load bearing surfaces of the joint. They're the structures that really need that. The tendons will recover, and they don't need so much time off, and they will be able to be slightly overloaded and still be able to bounce back. But a prolonged period, I'm talking several weeks of trying to walk on a joint that is not able to tolerate it, I think does cause significant long-term problems.
Do you think the ligaments, the healing of the ligaments, it depends upon that as well, or do you sense that they will heal regardless? Because I've always my sense is that the ligaments the laxity will be higher with not booting up.
I think that's a possibility. I mean, obviously, I think it would depend what forces we're going through and what range of motions we're going through. So yes, quite clearly, in the first stages, if someone is going to go over on again, a boot will stop that. So that absolutely would do that. But I suppose when I think back to patients' histories, when they're talking to me, I would say it's not often they said, "Oh, I kept going over on it in those first few weeks." It's that they're walking around on a foot and an ankle that just can't tolerate the load that's going through it. So I think that overall, I think the healing is slower because it's obviously the load and the out and the healing is mismatched completely. So it's always going to be slower. But I sense that potentially the biggest loser is the joint in there, and closely followed by the ligaments.
And I do think that's underestimated in physio rehab, is that you need to allow that joint time to calm down. I think we do quite often speak about the healing of the ligaments and the recovery of stability and strength, but we don't speak about the angry joint. And we're also starting to realise now that angry joints, big inflamed joints, degrade the cartilage, and that starts to lead to problems with the chondral surfaces, which is the arthritic problems. You can't go back from those.
No, and I think that's the thing. And I was going to also say, with the tendons, although I say that, I think that potentially, tendons can be overstretched too early on, and that doesn't help with the healing process either, as can ligaments. But yes, I think you're absolutely right. I think you can't go back from chondral damage.
Yeah, and I was doing okay actually on my left side. So we're talking about my kind of football injury at the moment, and that left side was doing okay. And I remember getting to 2-3 months, and I was actually training for this long bike ride. I was kind of cycling up to Leeds with some friends, and I got on a bike relatively early because I was behind on the training. This had happened when all my mates are pushing on, and I was getting a bit worried about it. So I got on my bike, and I remember even cycling flared me up. There was a ride I did, must have been maybe 6 weeks in or something, and I thought, I'll be fine because it's not weight bearing, and it flared me up.
And I think that's an absolute classic, and lots of patients will completely say, yeah, no, it's non-wavering. It doesn't count. And that you see in bone stress injuries as well, is the assumption. I mean, I've even had a patient that made their pelvic bone stress injury worse in water. It's a different question, but you can't just assume. There's still loads going through, and in cycling there's a lot that goes through the foot. Yeah, and this is where having that other person to guide you through is important, because it was a bad choice really. But in the end, there's a good chance that everyone will have a level of a flare up on their journey. Yeah,
and
of course.
It's understandable that happens, and it's just making the right choice on the other side of the flare-up that really
I think it's just in those first few weeks immediately post-injury that if you can get it in a boot, if it's a bad ankle sprain, it's or crutches if you can't, it's so important. Yeah, and I then remember actually taping it up for cycling and thinking it needed to be more stable, and that worked very well for me. I was then able to cycle for a few weeks with tape, weaned off that, and it was okay. I did that ride, got to the end of it, ankle was fine, no problems. I then had a half marathon booked for about 3 weeks after that ride, and I hadn't done any running, and this would have been 4-ish months post-injury. And at this point, it was feeling reasonably normal in day-to-day life, but it was still a bit swollen. But I had this run that I wanted to do, so I thought, well, let's give it a go. There's the AlterG treadmill at Pure Sports Medicine, so I was on that for. We'd structured a plan together, and we put together a sensible way of doing it. And even the first couple of those where I can't remember what I was on, maybe like 50% body weight, and it wasn't terrible, but it wasn't great either. I do remember that feeling of like, oh, am I going to make this? And I was in a bit of a hurry for it. Luckily, because of the cycling, my cardiovascular fitness was good. I just needed to get the weight bearing ready. But I think it was 4.5-5 months by the time that I was able to run a reasonable distance without my ankles swelling up. So, and that's the bone bruise, right? That's absolutely. That's what I've seen time and time again, and that's why I'm saying that very early on when I'm speaking to patients, just to try and manage expectations, because it becomes more frustrating. It's bad enough to have to go through waiting, but it's I think much harder to manage if your expectation is that it should improve in a few weeks. And I would say that's classic. Yeah. What you described. When you're helping someone get back to running, I've just mentioned that we had access to the AlterG. That's not always practical for some people, but how do you help someone go from the point of living their life relatively normally with a high-grade ankle injury, with a bone bruise, let's say, to getting back to running? What are the steps that are important for someone? Yeah, well, I think that walking tolerance is quite a good indicator, and I've learned a lot from that actually, because people walk a very varied amount. So asking people what they walk, so if they're not walking very much, and I want them to, or they want to return to running, then increasing walking is an easier way to build loads without it being too high. So that's something that I will want to do. But equally, in some patients, if they're walking kind of 18,000 steps, they might not have space for the running. So you'd want to kind of pull that down. And then I think I would obviously want to look at what they were like from a plyometric perspective, looking at their control. And then I would look at building in a kind of return to running plan based on their last successful mileage and how long they'd been out for. And I would, if I was concerned about sort of bone bruising being a factor, I'd only let them run twice a week in the beginning with 2 running-free days in between, because I think that allows better chance of tolerance. And most of the time I would, try to control the factors, like have only an easy speed, so you're not kind of trying to manipulate that as a factor, easy surface, and then start them on a walk running basis with that in mind, giving them, the kind of, I suppose, pain acceptance parameters, and that it's okay to feel a little bit, but you want it to be good to go the next day. And using sometimes, and I'll be very honest with the patients, is that this is our baseline test. We need to see whether we've got it right. I've worked this out based on what I've seen in your rehab and when you last ran. But, if we've got it wrong, we need to adjust it, so that I'm trying to give them the tools as well to be able to see how to react and know that even if I'm pulling back a little bit, it doesn't mean something that they've lost something. It's just that we're adjusting things in a way to get them back to their goal as quickly as possible.
I was having this conversation. We hosted our live event last night, actually, a little timestamp for the regular listeners. In the networking bit at the end, a couple of younger physios were just asking about how do we manage complex cases when they flare up? How do we deal with that? And in the end, it's just about that honest chat, isn't it? That honest conversation that no one gets better linearly. Everyone is going to have some level of plateau, some level of mini flare up or big flare up. And that isn't failure, that's information. That's how I always frame it for someone. It's like it's going to happen at some point. Here's our best guess at the starting point for you. It might be right, it might not. But even at some point, we'll make a sensible progression that doesn't work out well. And we use that information to then guide the rest of your journey going forwards. Having the ability to frame that up front takes away so much of the worry for the patient, because then when it does inevitably happen, they can usually think back and go, oh yeah, they did say this, so okay, maybe it's not the end of the world. Whereas without that framing, I've certainly earlier in my career, people come in a right panic.
Yeah,
like, oh, it's all gone wrong, it's all terrible. And even now, even knowing that I do frame it, people still come in and panic about it.
Yeah, and I think there's a couple of things there. One is that just because they have the return of their pain, they think that means they're back to the beginning. And I remember someone saying, oh, it's interesting because you said, even though I'm feeling pain, I'm doing more. And I hadn't really thought about it like that.
Yeah.
So it's also, is it really a flare? As in, and I think that's where the detail comes in, is really not just saying, obviously it's going to be a part of the journey. Of course it is, but also coming back to, was it actually a flare, or was it just that was the patient's interpretation? Whereas I felt that it was expected and I was quite happy, in which case we have to have a conversation about that. Or was there some aspect that I'd missed or that they'd missed in terms of what they did? So, patient with hip pain, and he had to drive and drop his daughter off in Edinburgh, and then he didn't really necessarily think, he sat down, that would be particularly bad, and that's really stirred it up. So I think it's also coming back to, if there is an explanation, then that links into, okay, so we understand that, we know where we're going. But then even also, you need to be careful, or I find myself having to be careful for the patients that are overly analytical and worrying about every single aspect of it. And then you have to kind of pull away from the detail and say, look, let me worry about that. You don't need to worry about all those little things. I will help you as long as you see the bigger picture and look back and say, well, so long as I'm doing more than I was 3 weeks ago, I'm good.
Yeah, I call that relative progress. It's like
exactly.
You might not sense that you're doing better because it still hurts, but to me, you're doing twice as much as you were, and therefore that's great. You've got the same pain for twice as much activity. So
yeah,
that's amazing. You should be really pleased with that. And people don't often recognize that in themselves. They need that to be explained or pointed out. So.
Yeah, and it's an understandable fear because they don't know that they've got better in the way that they want to until they have. But that's a really exhausting journey if you only can be pleased when you get literally over the finish line. So I think it's, as you say, it's important to go back and help people look at those sort of mini wins that they're having along the way.
With these chronic conditions, often pain is the last thing to go away as well, right? So I kind of draw that graph out. It's like pain is on this line, it'll stay the same, maybe kind of fluctuate a bit, but then over time it gets better. But what should happen is capacity of function is getting better really quite early without your pain going up. We call that relative progress. And that's kind of my way of separating the two things for the person, even though I know, because it then shows them that I know pain is really important, and of course we're aiming for that. It might just happen on the other side of all the other progress that we're making.
Yeah, and then, yeah, absolutely. And I guess if you're talking about a really complex case, obviously if it's complex, likelihood it's been going on for a long time, it's talking about the pain science behind it as well. Because sometimes you can get all of the loads and capacity improving and the pain doesn't change. And that's where having conversations about pain physiology are an important component from the beginning to understand whether that's likely to be a big thing that someone needs to try to understand to move forward.
How do you pick up on that in some of those early sessions then? Because I know that you can typically sense there's something different about this person's pain experience that doesn't quite fit. How do you pick that stuff up in the early stages?
Yeah, well, I think probably there's obvious, if there's an obvious kind of fear associated with movement, that's relatively easy to kind of look at problem solving with somebody because you can separate it out a little bit more. There is also, if there's very, very severe pain, not always activity dependent, or if there's something minuscule that has pushed someone to be very, very painful, then you always want to look back and think, what were the other factors behind that led to that episode? And I think just hearing people talk, I'll always ask people to explain things to me, and that's another massive thing that I've taken, is just because I think I'm explaining something really well, it doesn't mean to say that someone's heard it in that way. So listening to people, what does the scan mean to you? What explain your diagnosis. Tell me what you think is going to make you better. Because those things, if it's very, very tissue focused, and the surgeon said if they don't take it out, I've got something in my foot that's not supposed to be there. What are you going to do? And that sort of side of things. So it's hearing how patients understand that will also open up the possibility of if pain physiology and their association with their understanding of pain is a factor in their pain not improving.
This is another topic that came up again yesterday in our live event, that the hierarchy of the consultant and the physio, this concept in the patient's mind that the consultant is kind of leading this thing from the top and the physio has to kind of do as they're told from underneath. And we both know that doesn't really work out in practice when you've got a highly qualified and skilled physio. They're the expert in their own domain. You work with lots of surgeons. Have you found that on the whole these days there's a bit more of a collaborative approach with that, or do you still end up butting heads a bit with the surgeon saying one thing? Because you mentioned it a little bit there, didn't you? With the surgeon has told me this, and then I can sense that you clearly disagree with that. So how do you find that on the whole?
Well, I think that I would base it on the evidence. In this particular patient's example, he'd not done anything to look at settling tissue inflammation. He was really, really deconditioned and weak. And so I would want to answer that question before I sharpened my knife, but I'm not a I'm not a surgeon, so that's maybe not so surprising. I mean, I think probably I have selected over the years to work with the consultants that I think I work best with. And so I think the consultants that I work with, I think they will be like, this is my job as in the surgery, you go do your thing. And I think that works really, really well. Obviously, there are still surgeons occasionally that I'll see or work with because patients are coming to me and they've seen surgeons that I'm perhaps not working with so much. And I think in that instance, it's my job to give my understanding of a patient's presentation, and if necessary, write to the consultant if that is a way of I suppose putting across my understanding of their diagnosis and what I want to try to work on. And I certainly have been known to get passionate about probably the use of kind of steroid injections around tendons and things like that with consultants. And I will produce evidence and kind of push back quite heavily, especially in those situations where a patient hasn't had a chance to follow what might be a very sensible kind of treatment pathway.
With steroid injections and tendons, it feels a little bit like the point in time where we realised ultrasound didn't really work therapeutically for patients, and now consultants are having to come to terms with the fact that this modality doesn't work the way they used to think it, or at least has some has levels of harm that really need to be respected, and repeat injections are not good for tendons. Yeah, I think it's a lot of doctors are perhaps having that hard time of moving away from a modality that they're very used to using. Yeah,
it's really, really tricky because obviously a steroid, it can be magic, can't it? It can make you feel brilliant. But I think the LEAP trial, Alison Grimaldi's trial for glute med tendon, that was amazing because that showed that, which I wasn't necessarily expecting, is that when you compared steroids and physiotherapy in the very early phases when they took the outcome measures, that physiotherapy was better. So it wasn't, I can't remember how many weeks it was, but it wasn't long enough for them to have strength changes. So the thought was that it was because of an understanding. So the patient had better understanding. But the fact that could better steroids was incredible. And then I was like, right, this is it. I'm going to push back even more now because I suppose my understanding of or my concern with the steroids was dating back to when I was really fortunate to work with Håkan Alfredsson and assisted him in surgery and saw what the tendons look like. And you hear a lot of people saying, they're not going to rupture. There's no evidence that there's an increase in rupture. But then you look at the quality of it, and it just didn't look, not even under a microscope, it just didn't look normal. And these are obviously high-level athletes that have had, sometimes a lot more than 2 injections. But it really, really hit home seeing what they look like. And I think ever since then, which was, a long while ago, like 15 years ago, I have been very concerned about having using steroid, the use of steroid near tendons, because the other thing as well is, which I learned through Orcan, is that although you can look at an ultrasound guided injection and you can think that you're not obviously aiming intratendously, you could see that these injections had tracked intratendously, even though nobody would have been aiming there. And so that's a whole nother area, is that not only whether the steroid is indicated in the first place, but even when it is used, is it being targeted in the right location? Or is it in fact seeping in intratendously? And then is that having an effect on that tendon's subsequent ability to recover?
We are very nicely segued into tendons here, and I think that's great, because it's one of your areas of specialty. When you're considering tendons, how, in your understanding now of the literature and your experience as a clinician, what's the optimal way to manage a painful tendon?
I don't think you can answer that just saying a painful tendon. I think they're so different. Like if you take an Achilles tendon insertion, a mid-portion glute med tendon, or a proximal hamstring, they're just too different. So I mean, the simplest one is a mid-portion Achilles tendon, and that will behave in a very straightforward way. So I suppose you have to ask yourself in the first instance, is it problematic because it's underloaded, or is it problematic because it's overloaded, which you'll get from the patient's history. It's rarely to do, I would say, with the mid-portion Achilles, to do with biomechanics. That's not often a problem. And then you will, once you've decided whether it's under or overloaded, you have to look at what is the desired capacity that patient is trying to get back to, and look at where their current capacity is, and then build it towards that. And if they've been overloaded, and let's say they're running 7 days a week, you're going to have to take away a little bit of that abusive load, because they're not, I will talk to patients in selling that. It's like a mid-season athlete, is you can't go and apply more load when they're already overloaded.
Can't overload and overload. That's what I always say.
And I think when you describe it like that, there's I accept that, and so you have to find space for what you're wanting to do, and explain how slow load is different from the kind of stretch shortened cycle, which is a really hard load for the tendon to tolerate. And talk about the numbers as well, that when you're running, the Achilles tendon is having to cope with 6 to 8 times body weight, and if they're struggling, which they may do with a calf raise, and that's only probably 3 or 4 times body weight, and it's slow, explain to the patients the difference between those two goals, and setting very much, this is where you are, this is where we need to get to, and building up towards that. But equally, I remember during lockdown, the patients that just stopped doing everything. There were patients that went and did everything, but patients really stopped walking. They weren't going into work, and they had tendons that were really underloaded, and so their normal kind of, I'm going to go and meet my friend and walk, became a problem. And explaining that the tendon needs to feel happy. A tendon needs continued load. It doesn't like peaks and troughs. So that would be, I suppose, roughly the premise, with a time frame depending on how long they'd had it, of certainly no less than 3 months, and probably more like 4 months of a simple tendon. But an insertional tendon, or something like a proximal hamstring tendon, is a completely different beast. I've
always said tendons don't like holidays, and they don't like surprises.
No, exactly. That's I think that's very, very true.
Yeah, and I was very deliberately umbrella terming it, because I knew that there was lots to discuss when it comes to tendons. And let's stick with mid portion for now. If you've got, they're pretty easy to diagnose, aren't they, when it comes to a mid portion? You'd think, but occasionally you do see the ones that are posterior ankle impingement or something else is going on. But on the whole, let's say that we've got a barn door mid portion Achilles tendinopathy. How are you framing or designing your objective testing to get that idea of capacity, because I know you're quite detailed on this about what is the capacity of what you're trying to do versus what you have. How do you help determine the person's capacity?
Well, if you haven't got access to any particular strength testing, then you would be able to use a calf raise endurance test as a potential marker. The only caveat to that is that the research will tell us that they're weak on both sides. So I think there's an underlying knowledge that they are weak. So you're going to have to use strength as part of it. But when you're assessing a calf raise endurance test, you're looking at where they're cheating. So you might not necessarily you should come away with a number of how many they can do. But you're looking at, are they able to get up to inner range? Are they moving their body forwards when they're doing the test? Are they going into supination? And are they going to knee flexion? So ways around just doing a simple calf raise. Also, obviously, if you have the testing ability, then there's the force frame, which can look at, or other types of testing for soleus strength, which can give you an actual number, which you're looking at being probably 1.5 times body weight as where you're wanting to get to. And I think that having got that piece of data, as well as, I think, although it's not necessarily strength, I will use the numbers of what someone can tolerate walking wise to help guide where their current capacity is. That's part of my equation as well. And then testing for symptoms, a single leg hop test to tell me where they are in terms of their tolerance, looking at a VAS. Score. Yeah, exactly, a VAS. Because I think if pain is a limiting factor, I wouldn't look at the performance at that point when I was assessing them.
An ex-colleague of ours, Tim Maynard, who's now the head first team physio at, is he? I think he's still at Fulham, isn't he?
Yeah.
At Fulham. He taught me the calf raise height, and ever since I saw him do it in a session, I now do that as well, because you mentioned one of the cheats is not getting into inner range. And you say cheat, I would just say lack of capacity.
Yeah, I shouldn't be judgmental. You're absolutely right. It's a compensation because of a lack of capacity. So that's absolutely right.
Yes, and the way I would do that is you measure double leg first, so you get the potential, and then I would measure single leg as an isolated, so I can then help them understand that for most people, double leg is range of movement, not capacity. Every now and again, you get someone who's very weak and their double leg is reduced. But for the vast majority of people, double leg is that range of movement, and then the single leg is their ability to achieve that maximal range or that potential range. So I then work with them on that first. And because their body weight's too heavy for a single, for anyone who's reduced, we need to offload body weight. We're then going to lean forwards into it, or other leg's going to be offloaded on a step or a chair or something where I'm then making it not quite a single leg calf raise. I'll then modify the exercise to that until they can get good height.
Yeah, I think one of the ways, and I think we've talked about this before in rehab. One of the ways that my go-to exercise if somebody lacks inner range would be to use a double leg concentric and then shift, hold for a moment, and then single leg eccentric, because you're always going to be stronger eccentrically. And I think that works really, really well. And once the patient sees that they are different on their symptomatic side, that's a really good motivator to say, well, I know I need to improve that. I can see that I do lack capacity there. And that works really well.
So once I've got that picture, I'm considering this person as underprepared. That's my way of kind of helping them see you are underprepared for the task at hand, and that explains why the tissues have become overloaded. So that framework then helps them work towards becoming prepared for the task at hand, and they get an idea of they need to work hard towards it, build up their capacity.
It could be that, but I would also say, if you go back to the kind of, and I do see a lot of these, the patient that's running 7 times a week, is their tendon has lost capacity because it's been perpetually overloaded. So I think they need to learn how to work less hard.
I agree. Yeah, I was jumping ahead a little bit and saying, let's consider this person as not the overload. We're dealing with the underload. But I fully agree. It will depend on that person's typical loading pattern. But for that person, what you've just helped to see is that there's an objective assessment that's needed to give the data that creates that baseline reading, so that we can then move forwards and decide when they've reached a reasonable capacity to then go back to do what they want to do. How do you help them because we see so many bloody runners these days, don't we? So let's suggest this is a runner. How do you help them understand where running fits into that rehab journey?
Yeah, well, I think that most of the time I would want to keep a runner running. It's very unusual with a mid portion of the Achilles tendon. I think that I would stop someone running. Most of the time, if I have to, I will reduce their running. And then it's obviously in that first assessment when you're understanding how they've arrived at this point and what their next goals are. I've got in mind, okay, well, they think they're aiming for a half marathon in October or whatever it is, and I will be calculating whether I think that's going to be a reasonable goal or whether I think they might fall a little bit short. And if I do think that the maths don't add up necessarily, then I'll sort of talk to them about it then and say, well, you might not be fully recovered by then, but so you need to sort of think about what you want. Do you want to be fully recovered or do you want to do the half marathon? And that will be something that can happen in the background, and they can arrive at sort of intrinsically. But what I would say the key part of the first bit of my intervention is stopping the tendon being reactive. So if I can bring the tendon down with reducing the running volume to a level where it doesn't have to react, and we're seeing a reduction in the morning stiffness, we're seeing an overall slow dropping of the severity of the pain, then that is the impetus to do more. And obviously, so long as you've got space, the strengthening can be pushed quite hard without it affecting that kind of reactivity. So you can start off depending on what their capacity is like. I mean, obviously, if body weight is enough, you can't overload them. But if they're managing that well, then you're progressing to external weights. And, I would say it's helpful to be in the gym, but you can do weights at home for the mid portion and still be pretty okay, I would say, for the Achilles.
Something we've really enjoyed about using Jane app is Jane's Sidekick. So it's a little help bar that's been incredibly useful in the last few weeks. We had a new member of the admin team join and we had to train her up really quick. It was a last minute situation. And luckily, because of Jane's Sidekick, she was able to use the help section throughout her first few weeks, which meant less time me training her up and more time with Jane training her up. So loads of her questions were immediately answered by the Jane Sidekick, which is something I've not seen before. So made my life easier, made her life easier, made our business run smoother. So yeah, that works really, really well. And without further ado, back to the episode. And what's coming across here, and I know this about you anyway, is that the attention to detail on some of the loading side of things, including steps, including running volumes and speeds. Whenever I would come in for a session and I'd say, I've had a good week, you're like, tell me exactly what that means. And we're then going Monday, Tuesday, Wednesday, Thursday, what have you done? And you're pulling my step counter over and you're checking my Garmin. And it's that attention to detail that really stood out to me. And what is that helping you understand? And do you do that with everyone, or is there certain people that you don't think necessarily need that approach?
I would say, yeah, I remember James sitting in with me saying, oh my God, that was forensic level of detail when he was watching me with a patient. I mean, I think it comes up particularly if I to build my confidence that someone is on the right kind of pathway. And it comes from having seen patients where, they've come to me and they said, look, I'm doing all my strengths. I've been to see this amazing sports and exercise medicine consultant and, I've still got pain. And they've missed really important things exactly like that, is that they've thought, well, I'm running 5K. So it doesn't matter if I run 3 5Ks next week, not understanding the kind of weekly volume is a factor. And, I think I realised, early on when I'd sort of said, okay, we're going to start off with this walk run, I want you to do a couple of minutes running and a walk, and then sort of came about that this had been interpreted as sort of almost like sprint efforts. So I thought, well, if I don't ask that, how do I know what they're doing? So it's come from, I suppose, learning that, again, that idea of what it meant to each patient was perhaps slightly different. So I just needed to understand it, and I'll take all of it, and I'll often get my patients to fill in kind of, whether it's Excel or whatever, a document to look at all aspects of it until we feel like we're winning. And then, the detail is less important. So it's in that first phase where probably it's only going to be a patient that's got a very complex, long-standing injury that I would go, into that level of detail. So they've appeared on the surface to have done everything you would have expected, and yet they haven't got the results. And I think that they still ought to be able to get the results. So it's not so much of a structural limiter. I think they should be able to do better than they have. Then I will definitely go into that level of detail.
Once they're starting to make some reasonable progress here and they're moving towards the latter stages, something I'll often explain is that tendons are like springs, but when they're angry, they don't like being like springs and they can't tolerate springiness very well. So how do you help them transition into being more like healthy springs again?
Yeah, well, I think it depends what the patient's objectives with. In some patients, I won't do a huge amount of plyometrics, and their return to running, I'll assess their plyometrics, whether it's using the force sticks if you have them, or just observing them in clinic. But just running, if you've got that right, can improve the stiffness as well. In other patients, it will be more important to break that down and be more specific in returning the stiffness in the tendon in their plyometrics before they're really doing an awful lot in running.
And then you quite rightly separated the difference between a mid-portion and an insertional. So how would you manage that differently?
An insertional
Achilles.
Yeah, I mean, they're much, much, much trickier. Across all of the lower limb tendons, the insertional ones you have to be really quite big on avoiding stretch. So that means even small things like if you're sitting with your feet back into dorsiflexion, certainly not doing a calf stretch, obviously not doing any kind of loading off a step, thinking about in the gym lunges and anything that is increasing the angle of dorsiflexion, because all the little wins over those 14, 15 hours that they're awake that try to reduce that compression will give more opportunity for the loading to improve. And I think that it's probably what you take away for an insertional tendinopathy, Achilles tendinopathy, that is part of that ability to start to get somewhere. Rather than, I think, a mid-portion, it will just tolerate everything so much better. So, I mean, the main changes in the kind of program would just be that you're not going into any stretch.
I've got the simplified paradigm by Greg Lehman in my mind, where he said physio's really simple. We just calm shit down and then we build shit back up again. And I often say that to patients just to make it really clear what our main priorities are for their rehab journey. And it's almost like with the insertional, the calm shit down is almost the entirety of it. It's like you've just got to
that is the hard bit.
Keep calming it, and then there'll be a little build up on the other end of it, and hopefully it goes from there. Whereas on the mid portion, we don't worry so much about calming it down because it seems to tolerate the building shit back up again on the whole quite well. So I think as much as it's simplified, we've just really got to be clear on the diagnosis about how much of each part of that we're doing for that person.
Another thing that I would do as well with an insertion is I'd give them a heel raise, because the likelihood is that will help a little bit. It's not necessarily one that is like day and night, but along with everything else that you're doing, it would it would improve that. And I think an Achilles tendon insertion, I would also really look at the step count. I was laughing because remembering a patient of mine, I was trying to understand, she had bilateral Achilles tendon insertion and plantar fascia pain, and so we got to how many steps are you walking? About 25 to 30,000. So I was like, okay, well, I think we need to work out whether we can do a little bit less there in order to kind of get to the point where they're not in that reactive state. So sometimes trying to reduce their walking is an unfortunate part of trying to calm the shit down, as you say.
Yeah, you think at 25 to 30,000 steps that would have been their first thing to modify themselves. But patients make strange choices. Me as a patient has made some pretty strange choices. I'll come to one later when I'm talking about my right ankle surgery, and I'm sure you'll laugh at me again for some of the things I was trying to do. Before we lose our trail of thought on the Achilles side of things, though, there's a couple of cases I've had in recent years have sharpened my diagnostics a little and made me realise that I can't just. You mentioned earlier about posterior impingement, but the other thing that I've had a couple of times is the bursa inflammations, and they just don't settle with with
No.
either of those things, and they've ended up having to have injections to calm down the bursa because and the differential in the end for me was the shoes. They just can't tolerate shoes on their heel because the pressure is just too symptomatic. Is there anything else that you'd pick up on the diagnostics or the management of a bursa around that Achilles region?
Yeah, I think it's just exquisite, very local tendonitis, or not even, I was going to say not even tendonitis, it's just exquisitely painful, and reports of very high severity. And yeah, you're right. I think in that instance, then an injection can be good and is often important. The other thing that I have had success with is using a boot to get hold of, because it's just taking it out of action, stopping that load. And I think on the heel canter, absolutely is an important thing to discuss. And I'll talk to patients about having a really soft heel canter, something that's not kind of structured or pressing, and making sure it's not too high as well. And I have, only when patients have wanted to, got them to modify like the top section of their heel canter if that has been a particularly problematic area for them, in terms of that mechanical irritation.
Yeah, I remember that this particular one of the cases that sticks in my mind. She was wearing sliders and flip flops through the winter because she just couldn't handle a shoe on her foot. But within. Her pain went away and never came back after an injection.
Yeah, and as you say, there are those cases where whatever you throw at it, they're that irritable that they need to be taken out of action and settled like that.
Let's talk about my right ankle now, shall we? Let's go there. So, a quick history of that. I sprained my right ankle for the first time at 16 years old playing rugby. It was a forced plantar flexion injury with a sudden onset sharp pain on the front of my ankle, which was very sore in the moment, and then as a young, naive 16-year-old, kind of dismissed it. I did go to hospital. They fobbed me off, understandably to some degree, and said, "Oh, it's fine. It's just a sprain." And I'll use that word, "just a sprain," because it's an important dismissive word that doesn't do anyone any favors for a really important injury. So as a 16-year-old, I'm then thinking, oh, it's just an ankle sprain. I'll just crack on with life. And I wasn't given crutches or a boot or anything. And on I went with my life, walking around, limping. I remember limping for a good few weeks and it being pretty bruised and swollen. And I got back to playing sport again within a few months without doing any physio rehab because young and dumb and all that stuff. And I re-injured it, I think about 9 months, maybe a year after, ironically playing against the same team on the same pitch, and it was a very similar mechanism. I then went back to university at that time. I think that was when I just started university, so I must have been 18 at that point. Injured it again 2 months after that in a club, just slipped and felt it go. I then went to the university physio who, I think it was £5 a session, and she put some electrotherapy on it, gave me a calf raise. And to some degree, it kind of got better and was fine-ish for 15 years. And it was always my ankle that wasn't quite right, but I played rugby and played football for many years after that without any more significant injuries anyway. And then I was running a marathon and I had to make up a route at one point. I was running through a farmer's field and I rolled it in this really uneven farmer's field. And I felt like, oh, that went a really long way. That was weird. That's strange. I felt this kind of big sudden sprain happen, but it wasn't that painful. And I finished the marathon and thought, it's a bit stiff, but it's not that bad. That'll be okay. A week or so later, I was running. And in that week, I suddenly realized I was very aware of how uneven the ground was on that right side. I thought I just had to be careful on it. So I didn't do anything particularly crazy for a couple of months. Was still able to run, but it wasn't that bad. I then tucked my chair in at work and got my heel caught on the one of the legs of the chair, and it forced it again into plantar flexion. And I had this exquisitely sharp pain on the back of my ankle. It was by what I now know was the PITFL. Very unusual. And I was on a video call, so I had to style it out, pretend I hadn't hurt myself. But it was very unusual. It was right by Christmas, and I was then in a lot of pain, way more pain than I thought I deserved, given I'd just tucked my chair in. Was cursing myself that I was becoming old because I'd injured myself tucking my chair in, and ended up, it was so painful, I put a boot on it to walk around for a few days. It sort of settled down within 2 weeks, and I then realised, though, that it was something I needed to get sorted. So I went to see Dr. AJ Seth, who's a sports medicine consultant that we both know. We were both laughing about it, like, oh, you tuck your chair in, that's weird, it can't be that bad, maybe you pinched the capsule. Got an MRI on it. At that point, it became clear that my 16-year-old injury was much more significant than I'd thought. I'd fully ruptured my AITFL in that moment. I'd had a chronic ATFL injury that was, there was some scarring on the ligament. My PITFL was a new partial tear that explained the chair tucking in incident. And from that point onwards, my ankle was chronically unstable. I would roll my ankle at the most ridiculous of things, down the street, walking up the stairs, standing on a tiny plate in the gym. It would just collapse all the time. It wasn't painful, it wasn't swollen, but it was clearly unstable. I tried to rehabilitate it. It didn't really work. I remember going on a big long walk, like 90 miles in 3 days, and I probably rolled it 30 times in that 3-day period and fell on the floor at least 5 times with a big bag on my back. That was the week, that I realised I did need to operate on it, because I could no longer live the life I wanted to live. I had the surgery in a year and a half ago, so that was November 24, and had already come to see you and chatted to you about the journey, and we started our post-op plan from there. So I had a Brostrom repair for the ATFL and a syndesmosis repair, tightrope repair by Mr. Roland Walker, who I think is an excellent surgeon, and I really appreciated his communication as well throughout that. So I turned up to you, when was it? A couple of weeks after the surgery?
Yeah, I think
a couple of weeks after. And what was your thoughts on it at that point? Because we knew each other very well at this point, and I was then coming back to you as a patient, and was probably just looking for some expertise on it, because I was again a dumb patient and not making great decisions. So yeah, what was your thoughts around that?
Well, I think you're an extremely experienced physio, and I felt privileged that you wanted to let me help you in your journey, and I just saw it as you can't treat yourself, it's just impossible. And I just saw myself as another mind to help to reason and help decision making and guide what you were doing. And certainly, I can't remember whether it was that one or not, but I was looking, thinking, we need to have a chat with him. You'd had these ideas, obviously, because you've got your own business, that you were going to, I think I need to cycle back in here, and I can't remember what it was, but there was a long list of things. I was like, oh, and I think we need to kind of backtrack a little bit here. And we had a chat, and then we repositioned and managed to, I managed to convince you to take a little bit more time away from the load that you had initially planned in week, whatever it was, 3. And I think that was really helpful. And I think you came back one of the times saying, yeah, actually, you were right. It was good that we had decided to do it that way, because it would have been too much.
Yeah, because I was non-weight bearing I was in a cast for a couple of weeks. Then I was non-weight bearing in a boot for another. It was probably about 5 weeks in the end.
Yeah,
I was
tough,
non-weight bearing, which was a lot. And in my head, I was just going to then start cycling back into work. That was the stupidity that I was referring to slightly earlier in the episode. It's like in my head, I was like, yeah, well, as soon as I'm out, it's just cycling and it's fine.
I think that was exactly what you said to me.
Yeah, and then you're like, yeah, but you know that there's other cyclists on the road, and also you know that that's still not completely no load. And straight away, I just realised, like, yeah, obviously, I would never advise one of my patients to do that, and yet here I am saying that I'm suddenly at something special and I can do it. As soon as I come out of the non-weight bearing, I can cycle across London. It's like, no.
Yeah, but it's difficult, isn't it? You've got so many things that were pulling you back. You've got your kids, your business, and you'd had such a long period anyway. Even if you take those things out, you're wanting to get back to everything, and it is really difficult. And I think that's why it was great that you chose to work with someone, because I think it is so hard. I think it's impossible to be a physio to yourself when you've got a proper injury like that you're trying to come back from.
And in those post-surgical cases, what are you, other than obviously being sensible and listening to the careful nature of and letting biology do its thing again, right? We referenced that right at the beginning. Let biology do its thing. What stuff are you helping people with in those early weeks and months post-op?
Well, I think you want to separate, in this instance, out the ankle. Obviously, you've got to be careful with how you load the ankle, but you just want to load everything else as much as you possibly can, get them back to whatever they can possibly do as they're used to cardio, in being imaginative in any way possible to get them exercising the same minutes they normally are and doing as much as they possibly can and protecting the area that you'll need to then progressively build back, because it's really, really tough to go through a surgery like that where you've had to be non-weight bearing, you're out of action, not doing your normal thing, can't function in any of your normal, whether it's your exercise, your home and your work environment in the way that you want. And it's really important to feel human. And obviously the more that everything stops, the bigger the climb when you can eventually start. So you definitely want to do that right from the word go.
And one thing that changed my life was getting a knee scooter. And that knee scooter became such an essential part of me being able to carry on helping out at home, to carry on feeling like I wasn't trapped on my sofa or my bed. It just meant that I could move around and have, to some degree, my hands were free. It was such a game changer. And now I recommend to all of my cases that have anything similar that like get a knee scooter.
Yeah, well, I remember, I don't know whether you got it as well, but one of my patients was absolutely the same. He lived by himself and he was non-weight bearing, and he had the version that is, I think, more still. Like you can leave it in the kitchen. It hasn't got wheels, so it's smaller. Did you get that too?
No, mine definitely had wheels on.
Yeah, no, I saw but you didn't have two.
I didn't have the other one. I just used that, and I was
okay
because it was.
You had it in the kitchen as well as out on the street.
Yeah, I would wheel it around and clean the wheels when I came in.
Okay.
My wife Claire, she's very particular about that kind of stuff. So,
quite rightly.
Yeah, but I remember Christmas. I was helping out with some of the Christmas dinner and I was using it as a prop for me to then be able to do some of the prep.
It's so important, because not having your hands, you can't even make a cup of tea if you can't do anything.
Yeah, so I think that's a strong recommendation for anyone who's got clients who are going through this post-op or any non-weight bearing phase, is if they could get themselves a knee scooter. Incredible.
And this other thing, like I said, which is if you haven't got as much space, it was definitely something that was used in a similar way, but in a more static way. Yeah.
And what other things are you aware of in this journey then now? So starting to weight bear, what things do you consider in more of a post-op injury phase?
You mean specific, like
exercises, progressions, advice around different tactics to get the best outcomes? How does that differ from a typical injury when you're dealing with a post-op?
I have to think. I don't know. I think I would treat what I see. So whether that would that be wildly different? I mean, obviously the post-op is a planned intervention. So in terms of tissue healing, it's a little bit more predictable. So you can read that a little bit better than a more chronic. But I would still say you're still having to look and see how, whatever it is, if it's your ankle, how it's tolerating, and that be the guide. And it's probably a little bit more, as I said, predictable in a post-op case. I think, with ankles, I learned that, which I used with you, using a knee-to-wall test is a marker of how they're doing rather than something to push. I think that it's really easy to, I think my early days when I would do loads and loads of mobilizations and sort of thought, I'm not necessarily increasing their dorsiflexion. And I moved away a little bit from doing a lot of that because I think it would irritate around the anterior capsule. And so I think that was something that I learned myself in helping people as a guide. So like I did with you, if you use this and you can see, I know that I'm however many centimeters and that's kind of improving, then you're probably getting your load right. And if it's starting to kind of drop back a little bit, maybe you slightly overloaded it. I would say it's important to start off with loading the ankle in a sort of relatively low level pain. So you might be starting a lot of your stuff non-weight bearing, but then building obviously as quickly as possible back to supported and then single leg weight bearing as soon as you can.
I was pretty good with complex as well. So I was using neuromuscular electrical stimulation, and I think there's two factors here. Part of it is that you you feel like you're being proactive with your recovery at a time when you can't do much. There feels like there's something that's going on, and then physiologically we obviously know that it works. We know that it does lead to better
blood flow
outcomes.
Restriction as well can be really good.
Yeah, so I think that if they can get hold of that, or they can, I had access to one anyway, but you can get them relatively.
They're not that
affordable.
expensive, and I think if you're planning on using them for 3 or 4 months, it's well worth it.
And I've always said to people that, but buy it outright and then just sell it on eBay, because everyone's always looking for these things. So it's not going to necessarily be a huge outlay in the end, because you'll get that.
Definitely, I also say the same thing.
Something that jumped out to me in the prep call that we had, and it didn't surprise me, but it reminded me of your clinical style, was the clinical reasoning process that now runs through everything that you do. And the comment you made was that not necessarily what's the injury, but why now, why that injury. So talk us through what you mean by that.
Yeah, I think that's a really, really important thing that I want to satisfy myself with at the end of that initial appointment when I'm assessing somebody, because if you don't know why, then you don't have all the information to know how to stop it happening again. And it might affect your diagnosis, because if there really is, you've looked at everything and there really isn't a why, it makes you start to think, well, is there another, should I be looking at inflammatory or other areas here that I need to kind of investigate if there isn't an explanation that makes sense? So whether that is a load-based explanation, the components of, social stress, work stress, a combination of all of it that leads up to say, okay, yeah, I can see why these were the risk factors, and then with these coupled together, it led the patient to injure themselves in that way. And I know that Peter O'Sullivan, he had this quite interesting graphic and it was just a bar chart, but I suppose sometimes the visual things can really be helpful. And he had on the far right of this bar chart a really tall column, and then that was split into all the components that led to that acute event. And it's something, because obviously patients will come to us very worried often about structure, and you can see that the height of maybe the 4 or 5 other smaller columns, they're all quite similar. So there was the structural one, there was the pre-existing symptoms, but there were also all those other factors, and I want to know what all of them look like so that I can see what I need to put. That formulates my treatment plan, so I need to know what all of them are, so I know what I'm putting my kind of efforts into.
Even in my case, when I sprained it on that marathon that I was running, there's a good chance that wouldn't have happened if I wasn't on a really uneven ground. So right, that's a factor that's non-related to the structure. There's also a good chance that had I been running that not 3/4 of the way through a marathon, it wouldn't have happened. So then there's fatigue added to that. So it's not just structure again. So even in something that on the surface seems like it's just an acute injury, completely unavoidable, even in that example, actually you dig a bit deeper, there's some stuff there that you could easily fish out from that. You could also then say, I was supposed to be running that marathon in Scotland, but my friend had last minute cancelled it. Maybe there's even a bit of a stress attached to that, of this route that I'd never done before that I had to make up. So I've got to make, you could even potentially even argue a bit of that, right? So I fully agree. There's just such a fascinating myriad of factors that can link to the injuries that we sometimes see, that it's well worth exploring and going deep on the subjective side of things, and to not necessarily be satisfied in that first session that you've learnt everything, that there's probably more that keeps coming through if you keep asking the right questions and if you keep being curious about what's going on with this person. I get this sense nowadays that with a slightly more complicated case, it's only session 3 or 4 that I really get to the bottom of stuff. It's like, here's our provisional idea of what's going on, but we'll probably learn more and more as we go here and start connecting more and more dots.
Yeah, definitely. And I think that going back to what you were saying, about the different factors, is I think that even looking back at some of the endurance based injuries, is that it's how prepared that person was. Was their preparation appropriate, or had they actually not started when they'd intended to? So they're saying, oh, well, I've got a patellofemoral pain, and they've showed me that it's got this structure, but actually, would they have even had pain if they'd been strong from the beginning? They started their running earlier. They weren't doing any catch-up runs, even with that structure. And I think that's what I want to answer, because, that side of things leads really nicely into a much more successful outcome in the end.
Yeah, and I certainly hadn't prepared for a trail marathon. I'd been preparing for...
Well, that's what I was... Yeah. I vaguely remembered thinking exactly that when you told me, thinking, well, I wonder what would have happened had you been more prepared for that run that really was the one where it went. Yeah,
and it was only like a 5K stretch, but it was...
Yeah, it was bad.
Yeah, it was horrendous, yeah. On that concept there, so you talk about strength and let's just separate strength and stability. So we've spoken about assessing strength, and you've mentioned stability a couple of times. How do you separate those and explain those as different parameters for someone to be rehabilitating?
Well, I think it's by looking at the evidence. So, I mean, we talked before about calf strength, but I would also use handheld dynamometry a lot. And I can't even imagine going back to a time when I wasn't able to use that. That would be really, really tough, because although sometimes I might guess correctly, sometimes I'm surprised when I take the readings. I'm like, oh. And so that can separate it out and just say, okay, well, that's the strength contribution. So side-to-side symmetry, expected body weight, ideals according to whatever athletic activity they're trying to perform in. But then looking separately at their control, I would say, and how they are putting their sort of motor control, how they're putting together their movements when they're actually moving, because they could be strong, but they may not have the best movement strategies. And then that's breaking that down, slowing it down, and trying to build better movement patterns. And then adding the strength to that means that even if you're not always getting the movement patterns perfect, but you've got the strength, then you're often okay.
You can get away with it.
You can get away with a lot with being strong. Yeah.
And I remember phases in my recovery where I was strong but not stable, and it's certainly in my post-op journey, and that was the main, probably there was a good chunk of time where I was thinking, I just need to keep working at this stability exercise, just need to keep working at this balance exercise, and the skill was developing, but it took quite a long time, and even now it's probably not quite as stable as the other side, even a year and a half later.
Yeah, and I remember some of the stuff that we were doing in the gym, and I think there's improvements to stability, I think, are partly a barrier to that is the load. So sometimes a relative overload, even if it's something that you can't help, I think can slow the progress down to improvements in stability. So I think it's making sure that you've got both of those working well, and especially with something like an ankle where you're getting back, and obviously you can squat and you can there's lots of loads going through there, and you're back walking. But sometimes I think that it manifests its lack of full improvement with the stability still being a problem. I do see that quite a lot.
You teach you teach students. I know you teach courses. Now that you're an experienced practitioner, how do you help the newer physios these days map out their learning experience towards becoming more of an expert? Because there's a difference to even you're a little older than me, but even when I look back to what we were doing as students compared to what students are now doing, it's a very different landscape. So how do you help the next generation? What kind of advice do you give to younger therapists?
Yeah, I mean, I teach mostly to masters, so I don't have. I would be really interesting to know what is happening at a kind of degree level, because it would be very interesting to compare that to what I had, and I felt like I came out of my degree having a very kind of tick box, how do I assess someone? And I remember in my first placement in MSK thinking, I mean, I've done that, but I don't know what to do now. I don't want them to come back again because I don't know what to do. And I think, so, my answer will come with the students that I have been involved in teaching. And I think that it's looking at, because I've read so much about tendons, I can synthesize that and give them the nuggets that are really clinically applicable. And I use a lot of clinical examples because I think that makes it real. And really important with teaching is letting the students discuss their own experiences so they can ask questions and look at problem solving, because we don't learn unless we can apply it. I could say something, but unless someone's applied it, they haven't really learnt it. And so my courses will be very practical based as well, to try to put that together. And inevitably things will come up. So, if you're talking about something like a proximal hamstring tendon, the theory behind it, I will talk about how important it is to be, I suppose, very careful with stretch and compression, because they just don't get better. We sit on them all the time. It's really, really tough. And, it's I would say, very common still, despite that one of the first exercises people come up with is a single leg deadlift. And so that can be a point to kind of look at, okay, well, what made you pick that? Well, because I wanted it to be hamstring, I wanted it to be stability. There's a very good theory behind it, but it's looking back and seeing in real time, okay, so I can see I'm linking the theory there within this practical application of this exercise. It's not probably quite right. And even then, is it a desired movement pattern for that particular patient's sport? Because if it isn't, and it's high index of provocation, they may be perfectly able to get back to everything they want to without that particular exercise.
Yes, it's for that reason that I use it as my main provocation test. There's a loaded stretch in single leg. So a latter stage exercise in a typical journey rather than an early stage exercise is your point there, I guess.
Yeah, and I think it's going back to, how do I try to help students get some of the knowledge that I've got through the experience that I've got. And I think it's by trying to apply it. And I told them the theory, but it didn't help in there until they were trying to apply it. So I think that's a really, really important part of the teaching. And I learned that because early on, when I was first treating proximal hamstring tendons, there was really very, very little out there to guide. And there still is very little research. Anthony Nasser has come out with some great published work, which is on expert interviews. And so that's really helpful. But I remember reading it and thinking, oh, yeah, no, that's what I've done. So I had to work it out myself by, failing really. I was guilty of someone was like, oh, it's really tight, get in there with a tennis ball. And I thought, oh, okay, well, maybe that's the right thing. And now understanding how wrong that was. And I think that's something that I can use as a funny example when I'm teaching, because I hope that will make them think, okay, next time if they're thinking they're going to get their elbow out and try and sharpen it on someone's proximal hamstring tendon, that it's probably not going to improve it.
Yeah. Quite the opposite, perhaps.
Yeah, I would say highly likely. And looking at talking through examples of, if we take the proximal hamstring tendon as another sort of carry that through as an example of the exercise selection, and I think really getting in and explaining how I will be with the patient. So I think students are, whether they're a bit shy or they're just wanting to write things down, but I want them to be practically doing, like I said, you're the patient, you're the student, you're the physio, you're the patient. I want you to practice this and talk to them as if you are going through this. And something that I also come across with proximal hamstring tendons, where I think people are loading actually sometimes too heavy too early, and it maintains provocation. And that's not always the case, because we talked about the mid portion Achilles, and that I think that's pretty hard to do for that tendon. But it's an enthesis, the proximal hamstring tendon, and it's also in a very complicated area, so it's going to behave quite differently. And explaining clinical examples whilst I'm teaching, I'm hoping, is getting people to think back to their cases and how that might help their decision making when they're getting back into the clinic the next day.
What other nuggets do you tend to share in your lectures?
Well, because I'm still on proximal hamstring tendon, I think that probably another thing, and it's just because of what I've seen, that people will do is try to load in a single leg position when they're still getting proximal hamstring tendon symptoms. And I think one thing I have found that's increased my success levels is to try not to load in that particular. You can load the hamstring, but not in a compressive way. until they're not really symptomatic, so they're feeling in the mid belly. So talking about where do you sense that load is a question I'll often talk to my patients about, and that's why when I'm teaching with students, I want them to either feel it themselves, because most of the time physios are pretty fit and they're in the gym anyway. But if you're not, I do think it's good to feel it yourself and have a go. So I want them to do that to understand what they're then teaching their patients.
What exercises would fit the bill for that type of?
You mean
approach?
Loading a hamstring?
Yeah.
So if you wanted to take out compression, the easy win in the beginning is just something like a leg curl, prone. So you're not sitting because you don't want to sit. Take the hip into neutral, and yet you can load the hamstring, and it will never hurt. Very, very early on, if you've got a peel away lesion, you might have to be careful with the load applied to it. But I would say it's always a win. And then you use your double leg exercises like your loaded bridges, but you don't go into deep flexion because, again, you don't want to add that compression early on. And you only move out of that as you've got evidence that they're tolerating it well. You make sure they've got a really good calf, because that posterior chain will be affected, if you don't have that calf strength as well.
I think what comes across here, and it's something that came up in discussions with some of the guests at the event last night, is that there isn't a shortcut, but there are sometimes ways where you can learn from other people's mistakes, and that's what these conversations are often about.
Yeah.
You can't shortcut your learning, but you can accelerate it a little bit by just hearing other people's wisdom. But what you're saying there is you still need to experience it for yourself in order to really consolidate the learning for your own practice.
Yeah, and I think that's partly because every patient is different. I could say this works really, really well. I was saying to a patient in the gym, an example, I said, we're giving you this, which was a Jefferson curl. He was a patient that had a really nasty disc. And I said, this is a perfect exercise for you. But had I given it to you then, it would have been the worst exercise in the world. So you can't, there almost is no nugget, is there? Because it's where are they? How is that diagnosis affecting their particular life? What is their job? What is their family situation? What are their sporting activities? And the diagnosis will play out very, very differently depending on how it's taken up in that. So it is, you have to be curious, and you have to question, and you have to be open to learning from your experiences, definitely. And that's why I try to use clinical examples, because I hope a few of them will sort of resonate, and it will make people think, oh yeah, okay, I can see how I can apply that. But absolutely, I think that if you go to a conference or you go to a weekend and you think, right, I want the answer to this, it should only provide questions, not answers, probably.
And my final question is our traditional question for the podcast, and better never ends.
Yeah.
My tagline has been better never ends for a long time now. That's got a special meaning to me, but what does that mean to you? When I say that to you, what does better never ends mean to you?
Yeah, I remember when you were first thinking about what you wanted to use. I can't remember what I thought, but now when I think about it, I think that it means that you've got to you want to continually look at how far you can push yourself to another level, and there's always something to improve, I think.
My follow-up to that is, do you sense that there's a slowdown in your passion for physio, or are you as excited as ever to keep practicing?
Definitely, yeah. I think I feel so lucky to be a physio. I decided I was a gymnast when I was really young. We were talking about that earlier because your daughter's a gymnast, and I remember people training with air cast boots on, and I'd go home. My dad was a GP, and I'd had all these questions about their injuries, and I was always interested in what was going on. It was the mechanics behind it, and I didn't know what a physio was. So initially I thought I wanted to be a doctor, but then my dad organised some work experience with a physio, and I was like, this could be something. And I remember my interview at Pure, I was asked, well, if you weren't a physio, what would you be? And I said, well, I think maybe a car mechanic, because I like the diagnostics and I like the variety. I love the fact that I'm not sitting still. And I feel so unbelievably fortunate to be a part of people's life and help them achieve their goals. It's like the most rewarding thing, isn't it? I mean, when it works, it's a fantastic feeling. And I also think to have been a physio over so many years and to have seen, at the moment, I think I've got a patient that's 12 and a patient that's 93. The 93-year-old had a flying lesson for her 90th birthday. And, I have seen inside people's lives when they're their most vulnerable, rich, poor, at all different socioeconomic backgrounds. And I just feel so, so grateful for that. And I love the fact that it's always different and there's always a new challenge.
And I knew that you'd say something along those lines, because I could just sense the passion, and I've loved working alongside you over the years. I've learned so much from you, and I'm very grateful to have had that privilege of working with you and seen that and learned from you. So thanks for helping me learn, but also thanks for fixing both my ankles, because they are now fantastically healthy and I can do whatever I want. So how does someone find out about you, or if they're a patient perhaps, or they want to refer someone to you, how does someone get in touch with you or work with you?
Well, I work at Pure Sports Medicine at Threadneedle Street, so their bank branch. I'm not massively on social media. I do have Instagram, but I probably wouldn't say that's the best way to contact me. So probably through Pure Sports Medicine is the best way to contact.
Thanks very much for coming on. I've been looking forward to this episode a long time, and hopefully it's a little insight into sort of my injury history and how it's a funny thing, really, isn't it? Because I'm not always sure whether you should share your entire personal journey with it. But I thought for this particular episode, it made sense to use my two ankles as a bit of a journey through. Looking back on it, I'm incredibly grateful for what you did. So thank you so much for today and for helping me through that difficult time in my life.
Well, thank you for inviting me today and letting me be your physio. It was good to work with you. Yeah. Thank you very much.
Thank you. Thanks for listening to today's episode. If you've made it this far, that probably means you've enjoyed the show. Please leave us a review and subscribe to the show on whichever platform you use. I've been told that this stuff really does help us to reach more people like you. And if you are someone in charge of things at work, book a demo call with Jane to see it for yourself. Use code Physio Coach 2MO to get 2 months free. To stay up to date, follow us on Instagram at Better Never Ends, or on YouTube, the Physio Coach Podcast. This podcast is a product of Better Physio Group, provider of physio and PT services in central London, helping people in pain, suffering with injury to feel better and live better. There's physio, and then there's better physio.